Good evening, everyone. Neck pain is one of the most common problems nowadays, be it be youngsters or adults. Neck problems are not life-threatening, but they do cause pain and stiffness, often resulting in hindrance in daily life activities. Hence, BCIP is here with another webinar from the webinar series to educate us on the same. A very good evening to one and all present here. I, Dr. Priyanka Sharma, Assistant Professor, Banarsi Das Chandiwala Institute of Physiotherapy, welcomes our eminent speaker for today, Dr. Jibu George Vargas. Dr. Jibu is Professor and Principal at Faculty of Physiotherapy, Meenakshi Academy of Higher Education and Research. He is also an accredited Mulligan Concept instructor in India. The topic for today's session is a physiotherapy perspective to dysfunctions of the cervical spine. We welcome you, sir.
Thank you, ma'am. Thank you very much. On the outset, I think I should really congratulate all of you for attending. Those who are attending, I should really congratulate for putting some extra effort, for putting some of your personal time into learning again. I'm sure that you are already bombarded with a lot of webinars from your institution and outside the institution. So that's what's been happening now. So anyway, it's really wonderful to see many of our colleagues are taking some interest in attending these workshops. And God has been kind in these testing times when life is going through a very difficult phase for not just all of us, but throughout the world. God has been kind to keep us all healthy so far, and we have been doing well. And I would really like to thank also the management of BCIP and the faculty members of BCIP for organizing these webinars for the benefit of the students. And thank you very much for inviting me as well. And I would also like to thank all the participants and congratulate all the participants for being in one of the best professions that you can ever be in the world. So that's my experience that I'm telling. And I've been really privileged, I should say, and I'm thankful to God for being in one of the best professions that ever can be. So, well, I'm a part of the Meher deemed to be university, which is the Meenakshi Academy of Higher Education and Research, which is in the south of India, in Tamil Nadu, in Chennai. And I head the institution and the faculty of physiotherapy. And myself, I'm also an accredited, like Madam had already mentioned, accredited Mulligan Concept instructor, teacher, member of the Mulligan Concept Teachers Association, and have been privileged to take workshops within, in and around India and outside India as well, within the countries of Asia and Australia. And I have taken this particular topic because this is something that I would like to discuss from the clinical front, like in what we see mostly in the clinical side. So it's something really important that you need to understand. And as beginners, practitioners, it would be really nice if you could gather few points from here, take home points from here. And just because a 1 hour class on the cervical spine is never sufficient to understand in detail on the cervical spine. So I would like to hit directly on the points which I would like to discuss in this 1 hour. So topic being manual approach to dysfunctions of the cervical spine. I would like to touch upon what is clinical reasoning. As a physio, what would my understanding is we have a mixed group of physios who have already just entered into physio and who have already been in physio for quite some years. So clinical reasoning has been defined as a process in which the therapist interacting with the patient and other significant others, that is, it could be the family members or it could be somebody who's part of your health team, etc., regarding structures, meaning, goals, and health management strategies based on clinical data, client choices, and professional judgment and knowledge. This is the reference being Higgs and Johns in 2000. Now, clinical reasoning is a process based on deciding what could be the physical diagnosis of the patient or what could be the goal setting based on the priority of the patient, and what are the various physiotherapy management strategies that you would want to incorporate for your particular patient. So these are the various things that you would like to decide upon. And that process is called as clinical reasoning. And the discussion is the reasoning, whereas once you come to the diagnosis, it's totally different. So anyway, it's not a fixed process. One has to always remember it is a continuous process, because based on your treatment, what you see today need not be the response of your patient tomorrow. Because if you have given some sort of a therapy today, say for example in orthopedic conditions, you give him a treatment today, you might see a drastic improvement tomorrow. Or sometimes in some progressive neurological disorders, you might treat him today, and after a week, you might see that his condition is getting worsened, not by the very nature of, just because of the very nature of the problem itself. So if when it's a progressing disorder, so you can anticipate that he can get worsened, or your client can get better, or your client is remaining the same, all based on the nature of the disease. So we definitely need a clinical reasoning or a discussion on every day. As a clinician, one have to be very critical about the condition of the patient, and you also have to be critical about the therapy which you are giving. When I say critical, you should be questioning yourself whether I am doing the right thing for my patient. So that's very important. So that is when, as a professional, especially being a physiotherapist, you can make a very big difference in the life of your patient or somebody who is trusting you to help them. So many therapists do not realize it, that when, see, for example, when your patient comes to you itself, suddenly they come with holding the neck, they say they have severe pain here. Sometimes already you have a hypothesis made up in your mind. It could be this or it could be that. It is going to be this. So you may have some sort of a hypothesis decided in your mind. You may be right, may be wrong. We may be on the right side, we may be not on the right side, but that hypothesis orientation process is already existing in our mind. And many therapists do not realize it, but it's already happening in both the case of assessment as well as the treatment. So you, in your diagnosis, this is what you come across. And even before, talking in detail or doing a complete assessment, you also decide maybe this treatment can help the patient. So in both ways, it can be helping the patient, or it is the formation of hypothesis in your mind. And then again, when I say you have to critique yourself, you need to really question. Now, today you have given a particular type of treatment, and tomorrow the patient comes back saying, well, I did feel a little better. And then you decide, okay, are you happy with the amount of progression which the patient has shown, or the improvement which the patient has shown? Or do you think there is something else that you can do better? Now, let me not go into the details of it, because there are so many facets in that. Because, well, if you know that, yes, these options are there and I can try this and this is going to help your patient, you can definitely help your patient. But if you are ignorant of the fact that there are few treatments which are available, which can help your patient, and then, well, it's not your fault, but I would rather say it's your ignorance. So as a budding physio, I would always advise, always look out for knowledge wherever you can get it, whatever type of treatment is available. Always try to explore various aspects. And in today's knowledge explosive world, it's not a difficult task, but then what is difficult is to identify the right type of teacher to learn from and the right knowledge to acquire. So that's your challenge, and that's based on your intuitions and clinical, and based on your intuitions and your decisions. Now, all therapists have an element of routine to their examination. So, and individual therapists will have identified through experience the categories of information which they have found to be particularly useful for understanding the and managing patients' problems. For example, if you open one of the orthopedic physical therapy textbooks, you will see there are at least 30 to 40 confirmatory tests or so-called special tests which are given in the textbooks. But are you going to apply all those treatment for your patient, or all those special tests for your patient? Then you may be able to handle only one patient per day. So based on your experience, you will have to slowly start filtering out, okay, based on these clinical or subjective clues which my patient has given, this is what I would be trying. These are the tests which I would like to rule out for the patient. Now, one thing I would say to every practitioner, every physiotherapist is, if I may ask, what is the first step towards handling the patient? What would you say is the first step towards handling the patient? The first and foremost thing is to rule out whether this patient is our patient or not, which means I would say you need to identify whether this patient is indicated for physiotherapy or not. I can give a small example where once I had a patient who came to our department, and she complained of severe pain in the upper back. And then she traveled quite a long distance, and then I was not even able to assess her because of the severity of her pain. And then we put her on some modalities, and then we asked her for a feedback, and still we were not satisfied because even the modalities were not helping her. And checking on her movement patterns, every movement had given her pain. Every movement in the sense, flexion, extension, everything was severe. Severity was high, pain was high. But even though she did not have any recent episodes of fever, but earlier she had fever, and that just subsided with some medications which she had taken for the fever, pyrexia. And then the next instance, what we did is we did not ask her to come back to the next day, but instead we asked her to go and meet a spine surgeon, one of the consultants in the very hospital where we worked, where we were working. And then the spine surgeon had a detailed examination, and he immediately called up and he told, it's a very good thing that you send the patient to us, because even though we were at that time practicing first contact practice, um, that is something which every physiotherapy practitioner has to realize, especially when you think about first contact practice. Always our phase one is to rule in or rule out the patient, whether the patient is your patient or not. So the spine surgeon had a detailed assessment and identified that the patient has infective spondylitis. So when he says infective spondylitis, that means almost a vertebrae has been almost eaten up by infective organisms and pathogens, and then a few more sessions, a few more days, and she would have just, the entire segment would have just collapsed down, and she would have been hospitalized as an emergency patient. But luckily, God's grace, she was identified, and then from our department she was sent there, and then from there she was identified, and immediately she was subjected to surgery for spinal stabilization, and also the whatever infection was there had to be removed out. So you can imagine, if we were a bit enthusiastic and we were trying some manual therapy procedures there, we would have ended up making her a quadriplegic. So this is how serious your practice can be, even though most of us do not realize it. So you have to take it in a very serious sense. Every practitioner, every budding physiotherapist will have to take their practice in a very serious sense. And these are the days where we look after for evidence-based practice. But I always insist that the real practice comes from the role of the clinicians. So that's what I always feel. Practice comes from the clinicians, and it is the clinicians who practice based on the evidence. But in order to create evidence, you need to do some sort of a research. You need to document your practice, even if it is a single case study. And then based on your research, you form a database of RCTs or randomized controlled trials, and then that comes, the golden standards are being brought out. And from the evidence that is being brought out, clinical guidelines are created, and then again from there further research happens. And the same thing can also be used in patients. And if you see again further variations, again there is, it's a cycle. It keeps going on and on. So every time they come up with, sometimes this is better, and next time they come, that we have identified something even better than that, and then suddenly somebody comes up saying that all this is placebo, it's all the same, this or that, you don't need all that, you just do exercise, everything will be fine. So it just keeps confusing us. But then it is as a practicing physiotherapist, it is your intuition and your ability to identify from the available evidence which is more practical and which is more beneficial for your patient. That is when you start improving as a physiotherapist and you start developing your practice also. And just for that, you need to be really critical about what you are doing. So that's very important there as a physio. Please do keep in mind. So manual therapy practices have changed over the past decade in response to new knowledge, and they will definitely continue to undergo change and refinement because, like I said, every time there is research and something new is always identified. And musculoskeletal physiotherapists, be they clinicians or researchers, need to look at the outcomes. An outcome is something that which comes out of something. That means when you do a treatment and what is happening to the patient, what difference does it bring to the patient? So that's very important there. So whether it is and it has to be a visible or a practical result or an effect or product of whatever you do. So if you are giving manual therapy, so what happens to the pain level of the patient? Or if you're giving manual therapy or mobilization or manipulation, what happens to the range of motion of that particular joint? Or if you're giving some orthopedic treatment, what happens to the functional ability of that patient? So initially the patient was able to lift the arm only up to 40 degrees. So after your treatment, now she is able to lift up to 80 degrees. So does that really matter? So these are things which you really need to understand and you really need to look into. Now, for example, I would like to put forward a question. A patient is not able to lift the arm. Even this doesn't matter. Even the first years can answer if they are really keen on their anatomical knowledge. Now, a person is not able to lift the arm. So which muscles would you suspect? All the muscles of the shoulder. Now, what if I say that something from the hip level or the lumbar region is also influencing the movements of the shoulder? How is the quadratus lumborum connected? Well, if you go through the details of anatomy, you can see that the pectoralis major also has few fibers getting into a connection with the quadratus lumborum. So you know that the pectoralis minor gets inserted into the sternum as well as to the costal cartilage, and few fibers also do get inserted gets blend with the quadratus lumborum. So that's definitely it's something that you really can look into, and you will understand that the patient is not able to hyperabduct or is not able to lift the arm beyond 90 degrees, not only because of the shoulder muscles, not just the latissimus dorsi. You work on the latissimus dorsi. You can also work on the quadratus lumborum, and you can also work on the serratus anterior because it's also the hyperabductor muscle. So this is something that you really need to look into. So when you have a detailed knowledge of your anatomy, so you just get spot on target. And what makes a difference is your practice becomes different from another regular clinician's practice. You just touch, the patient comes to you with a shoulder pain, but you touch on the lateral aspect of the lateral aspect of the trunk, and you elicit a similar response. And the patient says, yes, when you press me there, I get pain in the shoulder. Why does that happen? So then you are confident as a clinician. So this is something to do with there. So you start working on there. You start working on the soft tissue there, down on the lateral aspect of the lumbar spine. You release it and then put him on to the exercises, work on the kinetic chain, and then you get him to do a full abduction. And then that's the difference that it makes. You make a big difference in just one sitting. Can you imagine? A big visible difference happens in just one sitting. And that is how you are going to stamp yourself as a practitioner, a good or a sensible physiotherapist in your community where you practice. And believe me, the patients or your clients or so-called customers are definitely going to identify the difference in you when you practice with good quality. So that's something that we always keep. Now, the other thing that you need to understand is whether the patient is having a primary dysfunction or a secondary dysfunction, or the patient is having only one dysfunction, or is it multiple dysfunctions. Now, these things are beyond the context of our discussion, but I just wanted to bring it to your knowledge so that you are keen on it. So one of the historic problems in this field has been the ability in obtaining a definitive pathoanatomical diagnosis for the vast majority of the patients with an episode of neck or back pain. So neck pain with shoulder pain, was it the shoulder pain or do you attend to the shoulder first, or do you attend to the neck, or do you balance it somewhere? So these are things which come usually with experience. So with this little introduction, I would like to go into the depths of the topic today. And I would like to once again introduce all the members of the Mulligan family here. These are the entire teachers of the Mulligan family. The gentleman in the black suit is Brian Mulligan. And coming to dysfunction, this is something which every physio will have to understand. When we talk about disorder, well, disorders are there, diseases are there, but a physio is more interested in dysfunction. So what do you say? What do you mean by dysfunction? You talk in terms of joint restrictions and muscle weakness, or you talk in terms of alignment, strength, stability, length, changes, alterations in the strength, changes in the stability, and changes in the length. And also the amount of care during function, how much efficiently the individual is able to perform the function. So now when you look at function aspect, you definitely as a physio, your observational skills have to be really good, because one thing you can see is the physio will have to be very keen with the way that the quality of the movement or the quality of the function. Now that is something that you have to really look into. It's not just the quantity. Now in your exercise, whenever you prescribe an exercise for your patient, it's very important that you see the way in which the patient does the activity. That's going to be very important. Now, why is it important? Because your patient can also compensate or substitute during a particular moment. Now, that is very important. So, that's very important as a clinician that you identify the quality of the movement. The quality of the movement is absolutely important there. And then coming to why manual therapy. So many people say, you don't have to give manual therapy. You can just right away do with the exercise. Why do you need to go for manual therapy? In fact, you can see there are a lot of articles which say that. Now, my defense here is like, what happens to a door? I'm sure that majority of us would have come across with this. Now, when you look at a door which is sagging down, when you see that, if the door is sagging down on this side, as a normal individual, what would you do if you want to open the door? You would hold on the handlebar and slightly lift the door on the sagging side, and then you just smoothly open it. Well, please let me ask you, what happens if you don't lift the door? If you just drag the door just like that, what happens to the door? You will be dragging the sagging end of the door on the floor. So that's what you would be doing. As a result, either the edge of the door gets damaged, or the floor gets sagged, or the floor gets carved. One of this is going to happen. So a joint which is malpositioned, a joint which is clearly malpositioned, what will happen if you start doing exercise without correcting the malpositioning? You will definitely start improving in the movements, but definitely at the cost of damaging the structures inside the joint. So what you need to do basically is correct it, correct the malpositioning, and then prescribe exercises. And the patient definitely has to do exercise, because exercise or active exercises is the mainstay for physical strength. So improving the strength of the musculature. Definitely exercise is very important. It has to be done. But if there is a joint dysfunction, that has to be corrected first. Because the joint dysfunction on the first place would have resulted because of a muscle weakness. But if you need to correct the muscle weakness, the secondary dysfunction, which is the joint, has to be corrected so that the movements of the joint is fine in order to get the muscle working. So that has definitely important there. And you would also definitely agree with me when I say a joint dysfunction can also lead to a muscle inhibition, isn't it? So you have also learned about the concept of muscle inhibition. So inhibited muscle, you can definitely provide stimulation and try to bring back the activity of the muscle, definitely. But at the same time, you also need to understand that the same activity can also be enhanced by improving the joint dysfunction. So sometimes even muscle inhibitions do get corrected by itself as a reflex when the joint malpositioning is corrected. So we do see that as well. Now, the human body, as God has created it, you know that there is lots of structures that you need to give your concentration into, which is the muscle, ligaments, fascia, articular surface, adherence of tissue, articular displacement, nerve, and intervertebral disc. These are things that we intervene on directly. And there are other things which we cannot directly intervene, that is the systemic sources and the space occupying lesions, genetic source of dysfunction. All these things we will have to probably re-refer the patient. And there is also something called as the dynamic instability. Now, you would have definitely heard from many of your classes or your teachers regarding the instability of a joint. Now, we have two types of instability, which we mention as the static instability, which is the structural stability of a joint being compromised. That is when we call it as a static instability, or a dynamic instability when the muscles are weak. Now, I resemble always the cervical spine, especially because of the large uh, coverage of muscles to a circus tent. Now, in the center, you have a pole which holds the circus tent, which is basically the cervical spine vertebrae. And then towards the periphery, you can see the many number of ropes which is holding the tent, isn't it? So these ropes, various ropes, are various musculatures that you see there. And those muscles are basically the reason for striking a balance in the cervical spine. So that is the reason why the person is able to dynamically move around with a proper balance. So one has to understand you have different groups of muscles, isn't it? You would have already learned in the cervical spine, you have superficial muscles as well as deeper muscles. So whereas probably the deeper muscles do the stabilizing effect, and you have muscles which travel all the way from the cervical spine, from the skull to the bottom of the spine itself. And then you have specific muscles which control movements within the segments. Now there are small muscles which connect between C2 to C3, C3 to C4, C4 to C5. And there are also specific muscles which connect from C3 all the way down, or skull, occiput, all the way down to cervical spine, or even to lumbar spine, or even to sacrum. So there are large group of muscles and there are short muscles. The short muscle decides on the fine movements, and the large muscles decides on the gross movements of the entire spine. Now that is why now you can see the number of ropes, and you will understand what we are discussing here. I'll come back to that slide. Now you can have a look uh, at the 5 different pictures. These are step-by-step classifications that we have here. Now on the first, we are having a kind of deeper deeper the layer of deeper muscles that we have, which are basically the interspinalis cervices. We have the spinalis cervices. We have the semispinalis, multifidus, longissimus, intertransversi cervices, and then intertransversi posterior and anterior. All those muscles can be seen there. Whereas in the second image, you can also see semispinalis capitis, longus colli, the rectus capitis anterior, additionally there. And then in the third one, you can also see the splenius capitis, semispinalis capitis, intercostalis, and the splenius cervices. So the different layers are adding up as we go down the line. Different layers are getting added. And you can even see the levator scapulae. Even the levator scapulae can be seen, and the serratus posterior can be seen. So all these muscles start controlling on the cervical spine, as well as you can, on the fourth diagram, you can also see the rhomboids again extending into the cervical spine, lower parts of the cervical spine, and also the sternocleidomastoid. And then you can also see the trapezius. So such a large extent of muscles, around 25 odd muscles controlling the cervical spine ipsilaterally. Then both sides, it's already there. So it's more than around 50 muscles. And talk a little bit on the osteology side also, you can see very well the orientation. Now in C0, C1, that is the Atlanta occipital joint, you can see the orientation is almost flat and just slightly curving upwards. So this assists the nodding movements. And then you have C1, C2, you can see that it is horizontally flat, almost parallel to the floor. And so it is, you can say it glides and purely anteriorly. Whereas the other joints that you come across here, you can see an inclination in the joints from between C2 to C3, C3 to C4, C4 to C5. They're all inclined upwards approximately 45 degrees, but individual variations do exist. For example, if Mr. A is 45 degrees, Mr. B can be 47 degrees, Mr. C can be 44 degrees. So individual variations do exist. So this is where basically the articulation happens, and this is of more interest to us. And this is the joint exposed, but you also have to realize that there is a capsule here because it's a synovial joint. So the articulations here are the intervertebral joint, the common intervertebral joint between segments that you see, and also the facet joints on both sides. Either sides you have the facet joints. And then understanding the etiology. So when you look at the common etiologies, what we see is carrying a heavy handbag by the shoulder, or carrying a heavy handbag by the hand, or labored breathing, coughing or sneezing in awkward positions, wrong postures of the cervical spine, and then the sternocleidomastoid and the scalene, and then following symptoms and not the condition. I'll come to that part. Now you can see these activities here. Now you can see one lady carrying a very handbag from the shoulder, very heavy handbag from the shoulder. Yeah. And the third picture, you can see a lady pulling a very heavy handbag using the hand. So in the initial picture, you see that what she is doing is more of shoulder elevation. And the third picture, you can see what she is doing is more of a shoulder depression, even though she is straining on her the shoulder elevators. Now let me ask a simple question. Can be a little confusing, but doesn't matter. It's always worth the try. Can somebody tell me what is the function of sternocleidomastoid? Not unilateral. Unilateral is definitely same side flexion and opposite side rotation. But what my question is about the bilateral action of sternocleidomastoid. What could be the function of bilateral action of sternocleidomastoid? Okay, so let me do a little bit of explanation here. Like now the attachments. With respect to the attachments, you can see that the insertion of the sternocleidomastoid is in this area here, and then it goes all the way up to the mastoid process, which is posterior. Okay, that's here. So I hope you can see the line, and this is what we anticipate it to be. So this is where it comes up with. And one edge is here. This is the sternal head, and then you also have the clavicular head again coming up there and joining together and getting inserted into the same side. So what happens here? Now, when you say a biceps brachii causes flexion of the elbow, why do you justify it causes flexion and why not extension? Because the line of action of the muscle is lying anterior to the joint axis where it is supposed to do the movements. So hence it causes flexion. So biomechanical explanation would be that. Whereas triceps brachii causes extension because the line of action of the muscle lies posterior to the joint axis. I hope you are clear with this. Now here in this instance, you can see that the sternocleidomastoid as a muscle is not just anterior or it's just not posterior. It's both anterior as well as posterior. Anterior, it is anterior to the mid and the lower cervical, and it is posterior to the upper cervical. So what do you think could be the role or the function of the sternocleidomastoid? It would be like some of you have already mentioned in the chat box, it causes extension of the upper cervical, but it also causes flexion of the mid and the lower cervical. I hope we are clear with this. Okay, so we have both the movements happening there. I repeat again, you can see the joints which are supposed to be moved are the facet joints or the apophyseal joints. You can see that the line of action of the muscle is anterior to the facet joints in the mid and the lower cervical, as well as whereas in the upper cervical it is posterior. It is posterior to the two joints. So it brings about extension at the C0, C1 and flexion at the other joints. Now when we say extension up and flexion down, so what does it mean? So can you just tell me what is the action? Or what is the function? It's nothing but the so-called poke chin posture. When a person sits with a poke chin, when you sit with a poke chin, it is flexion of your lower cervical or mid cervical and the extension of your upper cervical. If you ask me how it's an extension of the upper cervical, it's why does it become extension of the upper cervical? That's basically because now your area of influence or your visual field lies in front of you. So you would always like to see what is in front of you. Now, if you are drooping down, especially from the thoracic spine, when you droop down, and you also tend, the posture of your cervical spine also goes down. But your field of vision is anterior, so you would like to look up. So when you look down, when you are dropping down and looking up, it's just the function of the sternocleidomastoid. And if you have been doing it excessively, your patient has been doing it excessively, he is definitely overusing the sternocleidomastoid. So the point here is now, whenever a patient comes with cervical dysfunction, always make sure you assess the sternocleidomastoid. You are definitely, at least 90%, you are definitely sure to identify some triggers, strong triggers along the sternocleidomastoid. And once you do, you are successful in removing the triggers of the sternocleidomastoid, you will identify that your patient is completely relieved of the dysfunction. At least your patient comes and tells that majority of the patients would say, if he is not in the chronic stage, he would say, I feel much more relieved than what condition I was when I came to you. I feel a lot more relieved because I feel like a whole load of huge weight has been taken off my head and kept down. So this would be the patient's response to you. Okay, and then when a patient comes with a cervical problem, sometimes patients, you know how our patients are, many of them try to do some self-treatment. Some of them says, my relative told me to sleep without a pillow, or a particular person, my primary consultant, he told me to try to sleep without a pillow, and so I stopped using a pillow. When you are lying down supine, if you use a small pillow or a towel roll under the cervical spine, you are supporting the structures very well. Totally agree with that. But in your deep sleep, when you turn to your side, what happens to your cervical spine if you are using a small pillow? Can you see the distance between the shoulder and your cervical spine? Can you see this difference that you see there? So what happens to your cervical spine? You tend to move to the side, isn't it? You tend to do a lateral flexion or a side flexion to your cervical spine. And then you are in your deep sleep, so you don't even bother about it. You just continue with the sleep. And all you have is a small pillow to support you there. So it's very simple, and the person is going to get up with a strained or a sprained cervical spine. And he gets up in the morning saying that I think I slept in a very wrong posture. I have severe pain. I'm not able to even move my neck. So this is usually what happens. So please be well informed that what I would advise is, I definitely want my patient to sleep with a big pillow that would just definitely cover this size. But word of caution, I want a pillow that would adjust to the weight of the head of my client. So when I'm lying down sideways, I want the space covered up. When I lie down supine or when I lie down straight, when I place my head onto the pillow, I want the pillow to sink down to the weight of my head. I don't want a cotton stuffed pillow which is very rigid. That itself is really bad. I will explain why later. As we go down, I can explain. So I hope my message is clear, and I have given you also a justification for why I would say that. So just keep it in mind. So you will come to know when you start dealing with patients. Suddenly a patient comes saying that, somebody referred me to use a small pillow, and then finally I slept with a small pillow and the condition got worsened. So be careful with that. And so what's wrong with labored breathing now? You can see the third point is labored breathing. Well, the first point was carrying a heavy handbag, so you're lifting it up. And labored breathing again, what are you doing with labored breathing? So what do you say is labored breathing? When you start using the accessory muscles of your respiration, the accessory muscles of your inspiration are basically your scalene and sternocleidomastoid along with the other muscles. So again, you are straining on your sternocleidomastoid and scalene. Now, how many of you are familiar with the scalene muscle? So where is the attachments of the scalene muscle? Again, It's there in the cervical spine and it gets attached. The anterior and the middle fibers of scalene gets attached into the first rib, and the posterior fibers of the posterior scalene gets attached into the second rib. Now, one thing you need to understand is if you have all the three fibers there, you can also realize that you have nerves passing through in between. Okay, so normally it's designed when the normal tension is prevailing in the scalene, it's absolutely fine. We are very mobile. But when those muscles have been strained, like overused, and they are already under spasm or they are tightened up, or even in a poked chin, you can see that the scalene muscles are tightened up or tensed up. So what happens is the nerves passing between these fibers of scalene gets impinged, which you call as, or we call as the entrapment neuropathy. And sometimes we see patients coming with a diagnosis of cervical spondylosis with brachyalgia, which they mean to say is the brachial plexus is getting compressed somewhere. So that's what they actually mean to say. And sometimes it is a very sorry situation when we get similar patients and then they also refer the patient to be given cervical traction, isn't it? Many a times we are asked to give cervical traction for cervical brachyalgia. So what happens there in such situations? When a patient has labored breathing and the scalene muscle is tensed up and the patient has been carrying, or some other patient has been carrying a heavy handbag by the shoulder or by the hand, again she's been using the same muscles and she's been lifting it up every day back from her office back to the home. Maybe it's just a 15-minute walk and she prefers to walk, but she carries a heavy bag like this or by the hand, carrying it by the hand. Both ways she's training on the elevators of the shoulder, which could be the sternocleidomastoid, and she can also strain using the scalene. So in such situations, she can, in a chronic stage, over a period of time, she can start squeezing her nerves in between the muscle fibers or the muscle bellies. So in such situations, they are already stressed up, isn't it? And then on top of that, what happens if you try to give traction? The patient feels good when you give traction. At that particular time, the patient feels relieved. But when the patient gets back home, you either get a call or next day you get a feedback. I had severe pain in the evening, or the whole night I could not sleep because of pain. Because of the mechanical effect, you are just interfering with the pain pathway and you offer some sort of a relief. But then the pathology, the pathology of the muscle spasm still prevails, as a result of which patient started moving around and it goes for more reflex spasm and tightens up even more and increases the amount of radiculopathy into the arms, or the brachialgia increases. And then the patient literally loses sleep. And then the patient says, when I was keeping my hand like this and I was tilting my head to the side, I was able to get some sleep, but even that was not comfortable. You know, that varies with the amount of flexion the patient does. But of course, the patient is not aware of these technical differences or technicalities. But then as physios, we can definitely make out all these. But then we have to take care that we don't definitely cause the patient to go into that sort of an extent. We have to work even before that. We have to ensure that we do not harm the patient or do not worsen the condition of the patient. So you should be smart enough to understand your patient's situations. And then what happens during coughing or sneezing? Sometimes patients lie down by the side, they are in a sleeping position, or due to some nasal irritation, they immediately sneeze. So when they sneeze, what happens? They can suddenly cause dysfunction of the first rib. Can you believe that? The first rib can get slightly malpositioned or displaced. So when the first rib gets displaced, which muscle is getting into the first rib? We just discussed it is the upper fibers, the anterior and middle fibers of the scalene muscle. So when you have those getting inserted. When there is a joint dysfunction, it can cause a reflex spasm of your scalene. Interesting, isn't it? So again, the entire sequelae can happen. And the worst part is when your patient comes to you, he or she will not tell this component of the history, because a coughing or sneezing is a big deal. Like I sneeze always, but then this patient was sneezing or coughing in the side lying position and in an awkward position of a uh, very sensitive position, which could have caused a dysfunction of the first rib or the first costochondral joint, and then again leads to a dysfunction of the sternocleidomastoid and scalene. Clear? And all these etiologies are very important for physiotherapists. Maybe it may not be much of a point to the other practitioners, but as physios, these are very important point to us, and you really have to give it due importance and make sure that we are always looking into all the details of our patient's history taking. And then as a physio, it's very important that you follow the symptoms and not the condition. Like definitely the patient might be coming to you as a case of, let's say is a case of cervical spondylosis with brachialgia, and this is what the treatment you need to do. Or he might be referred as a case of disc disease or a disc prolapse, etc., etc., etc. But always remember, follow the symptoms. As physios, we treat the symptoms, we don't treat the condition. Let's say if the patient is coming to you as cervical spondylosis, are we going to treat the cervical spondylosis? No. Can you do something about spondylosis? No. Because what is spondylosis? It's a degenerative joint disease for the cervical spine. And definitely your treatment, our treatment is not going to change the degenerative status of the cervical spine. Instead, you can definitely work on the symptoms, look into the dysfunctions, look into the alignment, try to work on the functional aspect, and you can definitely make miracles happen. Now in Mulligan concept, manual therapy, we definitely work on the treatment plane, the plane of the motion, and the treatment plane is an imaginary line joining the two ends of the concave surface, and be working in that plane. Can be little too much for the first years and the second years, but it's worth understanding so that I can tell as when I was a student, when I attended my first manual therapy workshop, I went back like a small child who was given a bag of tools but did not know when to use it and how to use it. But it definitely helped me because the exposure to these treatment techniques at a younger stage definitely helped me to understand where I can apply it and when I can apply it over the years. When I started seeing patients, and in the back of your head, all these stuff need to be there so that it stays in your knowledge bank, so that you get when you get the opportunity to understand, to recognize when and where to use it, it definitely helps you. And then coming to the joint play, that is one of the most marvelous things that you can see in the creation of synovial joints when God has created. Now you can see two different types of joints. One is a knee joint above, and below you can see a mechanical joint, a man-made joint. Now the difference that you see is in the knee joint you find a lot of joint play, but below in the mechanical joint you don't see joint play. In the knee joint, if you don't have joint play, it's going to be an abnormal joint, whereas in the mechanical joint or a man-made joint below, if you have joint play, it's going to be an abnormal joint because it's going to give you clanking sounds, and then you call in a mechanic who would tighten up these joints. So most of the mechanical joints are known to be uniaxial, whereas human joints, synovial joints, are often known to be plain synovial itself is going to be a multi-axial joint, and even if when you call it as a biaxial joint, some joints are biaxial, I would still prefer to say that they also can be multi-axial. And then you have the ball and socket joints, which are definitely multi-axial. So that's definitely a blessing to have multi-axial joints, because the movements, the fluidity of movements, according to Kapanji, how Kapanji calls it, the fluidity of movements is really beautiful, and you can have a 360 degree rotation of your ball and socket joints. And even in the other joints, you have multiplanar motions. And Whereas in the mechanical joints, the man-made joints, you don't see that. But when God has created, He has created them in created the human joints or the synovial joints, even which animals have, in a very beautiful balance of ligaments, a very beautiful balance of mobility as well as stability. Now, being a Mulligan instructor, I would also like to touch on the principles of Mulligan concept. Basically, it's all about positional fault theory or positional malalignment. And one of the best example that we have to discuss regarding this is that of the ankle joint. Now, many a times we come across people who complain of twisting of the ankle and sprain to the ankle, isn't it? So many a times patients complain on the pain on the lateral aspect of the ankle. So for years together, people thought it was a problem with the lateral collateral ligament of the ankle. But then a small group of physios did identify that it's not just there, because the patient is still able to uh, slightly invert and there's no swelling, etc., etc. So many signs did not match with a typical or rather a conventional ligament sprain, and that's when they started working on the inferior tibiofibular joint. And when they started working on the inferior tibiofibular joint and started repositioning the joint and correcting the malposition of the inferior tibiofibular joint, they identified that once the correction was done, that is, they gave a superior lateral and a posterior glide, and then they did a small taping for that, and they identified that the patients had no more pain. There was absolutely no pain. And so, how did the ligament sprain suddenly get cured all of just with one single correction? So then they tried to prove that not all ligament sprains are sprains, but instead they can also be they can also be a dysfunction of the inferior tibiofibular joint, which was corrected, and then they succeeded in doing well with respect to such patients. So there comes up the positional fault theory, or the evidential support for the positional malalignment of joints. So here, treatment principles: it is important to continuously monitor the patient's reaction when you apply these manual therapy procedures, and then we investigate various combinations. Now, when I say a superior, posterior, and a lateral glide, well, there are again different angles to the posterior, or different angles to the lateral, or different angles to the superior. It's not going to be a pure superior, not a pure posterior, or a pure lateral. So you are going to have a combination. You're going to see the combination of all these three planes, and you, as a physio, you need to work on all the different planes. Now, in fact, when Brian Mulligan works on these planes, it's very interesting to see how he works with minute precision, changing the glides gently and changing the angle of his glide gently. So that's very important. And I have to also remind you, when we work on synovial joints, you have to understand the coefficient of friction is very low, very less, that it's very slippery inside. So all you have to give is a very gentle force, but then your force has to be on the joint. It should not be just pushing on the belly of the muscle or something like that, or just moving the skin. So as a physio, you should make your fingers, or especially as a manual therapist, you should make your fingers sensitive to the accessory glides of the joints. So that's very important there. And while sustaining the accessory glide, you ask the patient to do the movement which was painful, and now it should be without pain. Especially when you apply the Mulligan's concept, when you give the glide and you ask the patient to do, it has to be without pain. So that's the beauty of applying Mulligan's concept in all these joints. And symptom now should be significantly improved. The previously restricted and or painful motion or activity is repeated by the patient, while the therapist continues to maintain the appropriate uh, accessory glide. Failure to improve the symptom would indicate that the therapist has not found the correct treatment plane, the grade of mobilization is not appropriate, or the spinal segment is not appropriate. Or if all of these have been done properly, then probably the technique is not indicated. Probably it might be a systemic issue for the patient, or it might be some other issue which is not coming within the review of the Mulligan concept. So these are things that you have to really understand. And other important things I would like to definitely discuss here is with regards to, I did tell you that I will talk about what happens when you use a hard, stiff pillow. Now, just coming back to the slide, well, the gentleman there is Brian Mulligan there. And I would just like to come back to this slide here. Now, when you sleep with a really hard pillow, especially supine, now you can see these joints here. I did talk about the malpositioning of joints. When we discuss malpositioning, this malpositioning, we are not talking about a dislocation or we are not talking about a subluxation. Please be aware of those. We're just talking about minor movements which can be hardly 2 millimeters or 3 millimeters. So a dysfunction up to 2 or 3 millimeters can be really causing a lot of issues for the patient as such, because in such circumstances, there can be a anterior translation of the C1 or an anterior translation of the skull as well in relation to each other. So this can cause a big difference because, you know, the capsule which covers these structures, especially these joints, can cause, can be irritated, and the nervous supply which supplies the capsule of these joints incidentally also do supply the scalp of the neck, ipsilaterally or bilaterally. Okay. At the same time, you also do have muscles. Now we saw the muscles which come all the way from the thoracic spine to the cervical spine. Again, participants, please be informed. Maybe most of you are already aware of it, but you also have fine nerves which pass again in between these muscles and then enter into the occipital muscles, which enter into the top of the skull through these areas. Through these areas, especially through these muscles, the longissimus, etc. And then what happens there is, especially the smaller muscles of the back, splenius capitis muscles, when the nerves pass through these, and when you are slouching down, can you imagine when you are in excess thoracic flexion, and which is incidentally common when a person is depressed. When a person is depressed, he tends to slouch down. And then when he sits with a slouch down and then he starts moving his cervical spine, he is contracting all those muscles of the cervical spine which are also connected down. And then he causes a compression of the occipital nerves. And again, they are also incidentally supplying the scalp of the head. And all these reasons, these are reasons why the patient can have severe headaches along with cervical dysfunction. So we have techniques which we would either try to draw the C1 posteriorly in relation to the skull, or C1 anteriorly. This is with relation to the upper cervical and even with the posture of the thoracic. So that also proves, that also supports the statement that even with cervical dysfunction or cervicogenic headaches, it is worth mobilizing the thoracic spine as well, the upper thoracic spine or the cervicothoracic junction. And then we also have the C1, C2 joint. Again, the movements of the C1, C2 joint is predominantly the rotation. Out of the 90 degrees of rotation that you have in the cervical spine, 50% of the contribution comes from the C1, C2. That means 45 degrees contribution comes from the C1, C2. Now, if a person has a dysfunction of the upper cervical spine rotating to any one direction, then we have techniques where we also correct the rotation of the upper cervical, C1, C2 specifically, and which is clinically evident when your patient comes to you and the patient says, now the patients don't realize it's because of cervical rotation. What they say is, whenever I go to my boardroom for a meeting and whenever I sit rotated watching my boss, I suddenly start getting a headache. And some people might relate it to a psychological problem, saying it is definitely some stress issue, so you need to work on your stress, so that's what's giving you the trouble. Whereas being a manual therapist, you would be definitely tempted to check for the mobility of the right side facet joint of C1, C2 and the left side facet joint of C1, C2. And then you incidentally identify that probably the left side is affected during rotation to right, or it can be the right side restricted during rotation to the right. Well, I'm not going into the depths of the biomechanical normal coupling motion of the C1, C2 and the pathomechanics over there, but due to lack of time. But then we try to identify what is causing the problem. So a simple solution could be probably you ask the patient, you ask your client to sit on the opposite side of the table and start looking at the balls rotating to the left side instead of the right side, at least till when you can start, give him mobilizations and start strengthening his cervical spine with respect to the right side rotation, whether it be the right facet or the left facet. So remember, again I repeat, it could be a right facet which is causing the problem or the left facet. Movement can be in the same direction. So you, before till you work on it, you can probably advise him to look to the other side, and whereas you can help him on improving the mobility of the affected facet. At the same time, you can also prevent a progression or worsening of the situation by giving him a simple advice. So these are things that would help your patients if you can genuinely identify. And clinical scenarios, even this is also known to cause vertigo. Especially vertigo can also happen because of this. And again, that's involved with the neural aspect. Again, that's with the neural component which causes vertigo. And even with your upper cervical, C0, C1, the most common thing that ladies would say, especially when they, after they wash clothes and they want to dry the cloth, they look up to put it on the rope. They immediately feel giddy. And then this could be a clear sign of vertigo. And then you would like to differentiate whether it is because of your vestibular component in the ear or is it because of your upper cervical. So you do the special test accordingly to rule out whether it is the upper cervical or it is the vestibular. Rule out the vestibular first, and then you get a clue that yes, then this has to be the upper cervical, and you do the treatment accordingly. So these are points which is really important, and there are a lot more things we can discuss based on these things. So when you look into even with respect to this, like I told you, the upper cervical C0, C1. Now, when you use a really hard pillow and it is supporting only the skull, imagine only the skull is being supported, and then the cervical spine, the C1, is left free. And slowly, over a period of time, the C1 can definitely sag down. And that is coming away from its normal position. It can be a malpositioning which is caused, and over a period of time, you can get headaches. Or people who have the habit of lying on the bed prone and reading a book, or they keep the hand down there, lying down prone, and they watch movies or they watch something on the mobiles. They also are prone for giddiness or for cervicogenic headaches, or it can be the vice versa. So it depends on what is the precipitating factor which can cause these problems. So with these few slides, I did definitely have some techniques which I could have shown, but then maybe sometime later when we have time, we can do it, because that would go for another 1 hour. And with these few slides, I would like to thank you, Madam.
Thank you so much, sir, for providing such a profound knowledge of the subject. BCIP is highly grateful for your time and the effort you took for your thoughts and experience to share with our students. Thank you for
Thank you,
your
ma'am.
contribution.
Thank you very much, ma'am. Thank you for giving me an opportunity as well and inviting me also. And I